The Pdmp is a helpful tool for both prescribers and dispensers. Hi, I'm Rich Benedetto, and I've been promoting the use of Maryland's prescription drug monitoring program since I was licensed in this state. As a pharmacist, I regularly use the Pdmp in my practice. Since July 1, 2018, pharmacists in Maryland must query and review patient Pdmp data prior to dispensing any controlled substance if the pharmacist has a reasonable belief that the patient is seeking the drug for any purpose other than an existing medical condition. Let's look at our first patient that we've got today, Joseph Demo. He comes into my pharmacy with the prescription for OxyContin 40 and oxycodone 10 immediate release for 30-day supply, written by Dr. Paynes on September 28th. This is a good amount of pain medication, and I determined that I want to check the Pdmp before filling the prescription. The first thing you need to do when utilizing the Pdmp is to identify your patient in the system. CRISP has a fuzzy logic search to identify potential matches for your patient, which may or may not present a clear picture of their medication history. After typing in his information, the Pdmp brings up 3 different patients, organizing them by the likelihood of the correct match. All of the options have similar birth dates, similar names, and similar addresses. To determine if these are all the same patient, I'm going to select all 3 of them and review their prescription history. Here you see all of their medication history within the Pdmp. The first column represents the CRISP ID associated with each patient. You can organize the fills by person by clicking on the CRISP ID column header in order to sort the information. In scrolling through this information, I determine that these are different patients. We see that Joe Demo has the most fills, and Joseph and Joey Demo have different medications from different prescribers compared to Joe. Joseph and Joey have GI medications, while Joe has medications primarily for pain. Let's say Joe Demo is the patient I am seeing today based on the prescriber's name and medication on the prescription. I could leave this sorted as is, or I could go back to remove the patients that I don't think belong. To review the different medications Joe has received, I can click on the header Drugs Dispensed to sort the different medications. Based on this, you can see that he was previously prescribed a long-acting OxyContin, a short-acting oxycodone, and a couple of prescriptions for alprazolam. This seems to be somewhat reasonable and similar to the prescription that he presented. I will also look at the different prescribers who wrote the prescriptions for Joe. If I click on the prescriber's header, this will sort by the prescribers. I see that the patient receives most of their prescriptions from Dr. Test and some prescriptions from Dr. Tweet, Dr. Paynes, and prescriber scripts. I can hover over the eye or the tooltip beside the prescriber's name to review their information. By doing this, I notice that all of the prescribers have the same address of Prescribed Drive in Testopia. I would assume that these prescriptions are all being prescribed by colleagues of Dr. Test within the same office when that doctor is out. I also want to review when the past few prescriptions were filled. It looks like a 30-day supply for similar medications has been prescribed for the past few months, and the medications were filled near the beginning of each month. We do not see any deviation or significant increase in usage. These facts indicate that the patient is on a fairly stable medication regimen and regularly sees the same provider group. We do not see any indication that the patient is seeking medications from different providers, and likely he is being treated appropriately for his pain. While the patient is receiving a significant amount of narcotics, depending on his diagnosis, this may be appropriate. Our next patient, Josephine Demo, comes in with a prescription for Vicodin and Soma. Based on the amount prescribed, I determine that I want to check the Pdmp. I'll type Josephine's information and birth date into the computer, and we see that only one patient fits our information. When we review her medication history, we find that this patient is receiving a lot of different medications for pain. We see a long-acting patch, as well as immediate-acting morphine, hydromorphone, immediate-release oxycodone, Soma, and alprazolam. I can review when the medications were filled by clicking on the Date Filled header to sort by this date. I can see that she has had 3 different medications filled on September 1st, another short-term medication filled on August 10th, a 30-day supply filled on August 7th, as well as long-acting medications that have been filled multiple times in the last month. For instance, we can see a 50 milligram fentanyl followed immediately by 25 milligram fentanyl and a prescription for 50 milligrams less than a month later. We can also look at the day's supply. We see that fentanyl has been filled less than 30 days after the previous 30-day supply. These prescriptions do not seem appropriate based on the day supply and frequency of fills. We can also see this patient has multiple different prescribers from different locations and fills their prescriptions at different pharmacies. At this point, I would want to talk to the patient Josephine's prescribers about these medications. I would call all recent prescribers, letting them know that this patient is getting multiple prescriptions from multiple different prescribers and potentially using too much narcotic medication. I would also reach out to the prescriber on the prescription Josephine presented today with Dr. X to let them know about our patient's medication history over the past few months. Specifically, I would tell Dr. X the names of Josephine's other prescribers, their phone numbers, and types of medication, and how much was prescribed. I would want to determine how Dr. X would want to proceed. The prescriber should share if she needs to see the patient again, and if she wants me to fill the prescription. I might not feel comfortable filling the prescription based on the available data, and that is something I would communicate with Dr. X. If I make the decision not to fill the prescription, I will need to have a difficult discussion with Josephine. These conversations can be hard for both the pharmacist and the patient. Josephine might not be ready or willing to discuss her drug use, but having these conversations allows us to hear from the patient and learn why they have been visiting multiple prescribers for pain medications. I recommend using a non-judgmental tone, approach the patient with compassion, with an open mind, and listen to what the patient has to say. It may be that our patient has unrelieved pain and that their prescribers are unable to manage. However, we need to communicate the risks associated with their high opiate use, and we need to let them know that taking large amounts of opioids can be potentially deadly. I recommend talking to patients at risk of overdose about naloxone. The statewide standing order in Maryland allows Maryland licensed pharmacists to dispense naloxone to anyone who may be at risk for opioid overdose or in a position to assist someone believed to be experiencing an opioid overdose. A prescriber-specific paper or electronic prescription is not required for a pharmacist to dispense naloxone under the standing order. I recommend encouraging your pharmacy to keep naloxone in stock for these situations. I would also encourage Josephine to talk with her provider and potentially be referred to a treatment center to address her opioid use. These conversations are difficult but necessary if our patients are using more opioids than what is safe. If a pharmacist has concerns with a provider's prescribing practices, after talking with them, the pharmacist should consider contacting the appropriate occupational licensing board for them to further investigate. For more information, please visit marylandpdmp.org, crisphealth.org, or naloxonemd.org.